In this talk, I'd like to give an overview of diastolic stress testing with a focus on clinical integration. Diastolic stress testing is in part of both the 2016 and 2025 ASE diastolic function guideline, but we often don't hear about it. So part of this talk will be dedicated to seeing how it might fit into clinical practice. In terms of objectives for this talk, we will review the physiology of diastolic function, outline the key echocardiographic parameters for evaluating diastolic function at rest and with exertion, review the clinical indications and setting for performing diastolic stress testing, list the procedural steps for performing a high-quality DST, interpret results using established cutoffs, and recognize the technical challenges, limitations, and pitfalls, along with emerging tools for evaluating diastolic dysfunction. Before we start, I'd like to just note that diastolic stress testing, as Dr. Chow mentioned, is an active area of research. It's also incorporated in both the American and European ECHO guidelines at this time. But in this talk, I will focus on the most recent 2025 ASE diastolic function guideline and discuss the recommendations from it. I believe there was a recent talk about this specific guideline, so it's great that might be fresh in your guys' minds. So please have a look at that video as an introduction to this one. And later in this talk, I will bring in several key papers that explore the clinical validation of diastolic stress testing in order to keep this talk clinically relevant. So let's start with a quick focused overview of LV physiology during exercise. The basic contractile unit of the myocardium is the sarcomere. It's made up of several key components. The first is the tightened filament, which acts as a bidirectional spring element. So when it stretches, it accumulates potential elastic energy and will want to contract. And when it's contracted, it will accumulate elastic energy again and will want to decompress and spread out, which generates forces in both directions in a push and pull kind of fashion. Second, we have the interplay between actin and myosin. Myosin is a protein that walks over actin, thereby compressing the tightened spring elements in systole, and it uses ATP. And third, we have the troponin-tropomyosin complex that prevents myosin binding to actin. So when calcium enters the cytosol during systole from the plasmic reticulum, it binds the troponin and unblocks actin binding sites, allowing for a much faster, more powerful contraction. And so all of these three components are important during both systole and diastole for LV function. We all probably have an intuitive grasp on how the LV works during systole. The sarcomeres generate that contractile force, which pushes out the blood into systemic circulation. With exercise, there is a higher demand for blood, so the LV must increase cardiac output. One of the ways it does that is through increased contractility. And so it does that through increased adrenergic signaling that leads to more rapid calcium influx, which allows for myosin to have more contact with actin. So more time of contact, thereby generating a more powerful stroke. Adrenergic stimulation also promotes vasodilation, which allows to bring in more fatty acids, more sugar, more oxygen to support ATP production in the myocardial tissue. And then adrenergic stimulation also promotes increased heart rate and stroke frequency, thereby increasing cardiac output again. And finally, every time the ventricle fills with blood to the brim, the elastic recoil from those stretched out tightened fibers will further enhance the rapid initial contraction phase at the start of systole, which has also been described as part of the Frank-Starling mechanism. So that's what happens in systole. But when the heart rate rises, there is a shortened amount of time in diastole for the left ventricle to fill. So in diastole, the LV must accommodate for that shortened time. And so to be able to maintain LV filling, otherwise the LV is going to be pumping basically empty space, and that will reduce blood pressure and cause a reduced cardiac output. So in diastole, it's essential that the LV is capable of increasing its filling rate during a shorter diastolic period, which is a pretty significant task. So one of the primary mechanisms is that same elastic recoil force that's generated when the ventricle is fully compressed. This recoil force allows the LV to generate a much larger transmitral pressure gradient, which we typically see as the Doppler E wave on the echo. This leads to increased LV filling and preload in between every stroke. There are other mechanisms that further enhance LV relaxation to further help with filling. Altered levels of phosphorylation throughout the cells are able to phosphorylate various channels on the endoplasmic reticulum, which will help suck up and sequester that calcium in between every stroke. And then it would allow a much more powerful calcium influx back into the cytosol in systole. Phosphorylation also modifies troponin sensitivity to calcium and passive stiffness coefficient of titin protein, which further optimizes relaxation speeds and even further during diastole. Here, I'd just like to reinforce the idea of the elastic recoil force with an analogy. The LV actually has these helical fibers that mimic a spring, or you can think of it as maybe a snake that coils up preparing to jump, and at the end of every systole. And when that potential force gets captured, it is released, the ventricle and the snake rapidly grow in size. And this allows the ventricle to generate that relatively negative pressure compared to the left atrium, which just sucks in blood into the ventricle. So then when the LV is full, it stretches out fully the other way, and using that Frank-Starling mechanism, that opposite spring contractile force, it's able to do kind of a very similar push back and push the blood back into the systemic circulation. Historically, we have been able to measure LV filling pressures by inserting pressure transducers into various blood vessels and heart chambers, which has become known as hemodynamic evaluation, and this remains the gold standard up until today. This Wiggers diagram in the middle shows the interplay between LV and LA pressure in the diastole phase. As LV pressure drops, LA pressure becomes higher, which allows the blood to flow along the pressure gradient into the LV as part of the rapid filling phase. The second phase is the atrial contraction, which again raises the left atrial pressure to allow even more blood flow into the left ventricle. When echo was developed, we also realized that we can use it as a non-invasive surrogate for measuring LV filling pressures. In its most basic form, the two phases of LV filling manifest as E and A transmitral velocities on the Doppler mode. There's also a corresponding E prime tissue velocities of the LV base that move as the LV is filling. These E and E prime parameters have been shown to correlate with LV filling pressures. There's actually a whole slew of echo parameters that have been shown to correlate with LV filling pressures. And many of these are fairly novel, and they're not used in day-to-day echo process and study. A lot of these are difficult to acquire and to capture. Some of them, as I mentioned, are novel and don't yet have enough evidence to be in guidelines and in protocols around the world. And there's also an absence of standardized software packages for some of these more complicated parameters as well. But here are the parameters that are most well studied and accepted as markers of LV filling pressure, and they're also very relatively easy to acquire and repeatable in between operators. So in terms of invasive testing, the pulmonary capillary wedge pressure and the mean pulmonary artery pressure correlate well with the left atrial pressure and LV filling pressures. So normal wedge pressure is below 15 millimeters of mercury at rest, and these are obtained on the right heart catheterization in the cath lab. In terms of the echo parameters, the E over E prime ratio is the most studied parameter. It has been shown to very closely correlate with LV filling pressure and wedge pressure on invasive hemodynamics. It's also easy to acquire with low inter-operator variability, and it is easy to measure as well on the images. Normal E prime velocities are on average larger than 6.5 centimeters. Depends if you take it from the septal segment or the lateral segment. And normal E prime ratio is on average less than 14. Additional parameters include TR velocity and RVSP, which can further corroborate that elevated LV pressures are transducing through the pulmonary vascular circulation into the RV, and also the left atrium volume index, which indicates chronic elevation of left atrial pressure. So in summary, echo really does provide a little bit of a better value proposition than invasive hemodynamic testing because it's much more accessible, and it can be done both in the outpatient setting and the inpatient setting, rather than a right heart cath that requires a cath lab. It's also safer for the patient, so there's no puncture, skin puncture, and there's also no radiation. It also ends up being cheaper per patient for the healthcare system. And so overall, echo has become a very useful tool to look at diastolic parameters. So let's have a look at how these parameters change with exercise and when diastolic dysfunction is present. So up here at the top, we have the echo parameters both at rest and when there is diastolic dysfunction at rest. And these are taken directly from the 2025 ASE diastolic function guideline. So I invite you to have a look at that guideline and to feel free to review them. And when we move down to the bottom row, this is what happens with exercise. Virtually all the parameters are going to be rising because of increased blood flow and increased pressures in both the pulmonary vasculature and the left atrium and the left ventricle as well. So the wedge pressure ends up rising, but is normal when it remains under 25 millimeters of mercury with exercise. The E velocity will increase arbitrarily, and it really depends on how much blood flow is able to be generated. So athletes are going to be generating a much higher E velocity, and normal people, non-athletic people, are going to have a bit of a lower, but all of it should rise. And there hasn't been a correlation found with the actual left LV filling pressures. So it's not a good predictor of dysfunction. However, the E prime velocity will also increase, but not as much. And this will allow the E prime ratio to go up mildly in a healthy person. A normal E prime ratio should be about 6 to 8 with exercise, but also below 10 for most cases. However, in diastolic dysfunction, E prime is going to fail to increase due to a failure in relaxation. And so the E prime ratio is going to go up much higher. The cutoff described in the guideline is the same as at rest, which is above, on average, of 14, with, again, changes whether it's a septal or lateral area. The guideline itself uses only average and septal parameters, but other studies have also described lateral EE prime and increase in the whole proportion by 1.5 times. TRjet is that additional parameter that is associated with diastolic dysfunction when there is an abnormal E prime value. It is helpful when combined with that EE prime ratio. It's abnormal when it goes above 2.8 meters per second, but by itself, it's not predictive alone because, for example, healthy athletes can generate a very high TR velocities on their own without having an abnormal E prime value. So to sum up this slide, our understanding of diastolic dysfunction at rest and with exercise hinges on basically pulling together a bunch of different parameters and finding optimal cutoffs based on population studies. And so we have this binary understanding of multiple parameters and how they interplay. Possibly in the future, we'd be able to take in the whole continuous spectrum of these variables, and algorithms such as with artificial intelligence may help us have a better, kind of more finer tuned understanding of how these can be all integrated together. But so far, we're just using cutoffs in the current guideline. So now that we've learned a little about diastolic physiology and echo parameters for measuring LV filling pressures, let's talk a little bit about the application of diastolic testing in a clinical setting. So for context, and I only found American statistics, there are about 6.7 Americans living with heart failure at this time, expected to rise by a good percentage by 2030 to 8.7 million. About 40 to 50% of those people have heart failure with preserved ejection fraction. So when they have a normal LV contractile ability in systole. And the statistic I found the most interesting is that 50% of those with HFpEF have a normal resting diastolic echo parameter, which is where diastolic stress testing will come into play. and up to 30% of people with HFpEF have a normal BNP, such as, for example, people with obesity. And so BNP ends up not being a great test and will provide a significant number of false negative tests, false negative results. So some of the risk factors for the developing diastolic dysfunction: age is the biggest contributor. Age is really sort of the bane of cardiology practice, as it drives so much of cardiac pathology. It's really the biggest risk factor for most of cardiac disease. However, there's also some preventative risk factors, such as hypertensive cardiomyopathy, ischemic cardiomyopathy, and it's a little bit less preventive, ones that are preventable, such as aortic stenosis and hypertrophic cardiomyopathy as well. And there's really only one protective factor for diastolic dysfunction, and that's exercise, because it builds up those sarcomeres, it builds up more of those tightened spring elements, and so the myocardium becomes bigger, more powerful, and it can compress and decompress better. Exercise also improves the pathways that manage hypoxia and oxidative stress, so a more athletic heart can better tolerate these insults, which leads to less fibrosis and diastolic dysfunction over time. In terms of a real-world scenario, the main indication for diastolic stress testing is for dyspnea and YD. And we have the goal of going through the cardiac and non-cardiac differential for dyspnea and systematically ruling out cardiac disease. HFpEF as a syndrome is often the primary concern in this patient population, and the patient have a fairly normal diastolic function at rest. It either is normal or it is grade 1, so mild changes on the resting echo. And the typical clinical setting is an outpatient clinic, as these patients are going to be ambulatory with some bothersome symptoms that affect their daily living. So the referral comes in for chronic dyspnea of unclear origin, and we're seeing this patient. And the first thing we're going to do is take a detailed history and exam and order some basic investigations with the goal of ruling out non-cardiac causes first, such as pretty common things like anemia, lung disease, and MSK disease. And then we often order an echo to rule out a variety of structural disease, such as valvular disease, pericardial disease, wall motion abnormalities that could suggest ischemic cardiomyopathy, pulmonary hypertension, and hypertrophy as well. If all of these come back negative, then we've made our way through a lot of the differential. And so then we can move on to evaluate the diastolic function in isolation. And so if there are signs of grade 2 and grade 3 diastolic dysfunction, then we've pretty much made the diagnosis right there of HFpEF. And so we would think that only the diastolic dysfunction is something that drives the patient's symptoms. However, if the diastolic function is normal or grade 1, then we have to go further to increase diagnostic accuracy with a diastolic stress test or an invasive right heart catheterization, depending on the clinical context. And I'll discuss when we might want to get a right heart cath a bit later in this talk as well. To run a diastolic stress test, we first and foremost need an experienced ultrasonographer, familiar with the protocol and skilled with the probe. We might also need an exercise technologist, depending on which center we are in. And we will be evaluating for wall motion abnormalities together so that we can make the test more efficient. We'll be running pretty much a standard protocol to achieve a target heart rate. And the recommended equipment for the exercise will be a supine bike ergometer, which can increase resistance gradually. It also allows for the patient to be still, and we are able to get scanning images basically at every resistance level. However, some centers, and many do, have great treadmills, and so that's also a valid modality to use for the exercise test. Some additional maneuvers for heart rate increase include hand grip, squeezing foam balls, Adding a saline bolus to increase the preload. Can also you do that with a passive leg raise as well. Dobutamine stress is not recommended because dobutamine actually improves LV relaxation and essentially improves diastolic function. And it's also not a good surrogate for the physiological changes that happen with exercise. So exercise is the main stressor that we want to use in this test. So if the patient's on a supine bike, the patient is fairly still, which will allow us to scan the patient at each level of resistance. We will be able to get wall motion, E and A velocities, E prime velocities, and the TR jet. But if the patient is on a treadmill, we can only really scan before and after exercise. Right after the patient is reaching their target heart rate, we're going to ask the patient to quickly move to a nearby bed and lie on their side. There is thankfully a very small window of opportunity where LV pressures remain high for several minutes after exercise is over in the recovery phase. So we're able to quickly get the parameters we need. There is a specific order that needs to be followed based on the fact that there's such a narrow window of opportunity. First off, we're going to scan for wall motion, and then we're going to scan for the TR jet. We can't scan for the E and A velocities or E prime velocities right away because during high heart rates, there's a phenomenon called EA fusion. And so it doesn't allow us to get accurate values for E and A waves. So we have to wait until heart rate slows down enough, around 110 or so, and EA fusion resolves. And then the first thing we need to get is the E prime velocities. And this could be just one of the velocities, such as the septal velocity. And then we would get the E and A velocities as well. Now that we have all the measurements, we can use this diagnostic algorithm for HFpEF, which comes from the 2025 guideline. So starting kind of on the left at the top, if there are wall motion abnormalities, we're able to diagnose ischemic cardiomyopathy. So we can stop there. But if there's no normal wall motion, then we have to move on and look at measurements of the E prime ratio. And so we have lots of options to choose. So if the average E prime is above 14 or septal E prime above 15, lateral E prime has also been described in some studies, and increased E prime ratio has also been discussed, but is not specifically mentioned in the guideline. So if all of those are normal, then HFpEF is unlikely. And then we have to move on to look at the TR velocity. And TR velocity is one of those things that essentially enhances our diagnostic accuracy. So if the TRV max is below 2.8 meters per second, then it's unlikely that diastolic dysfunction is propagating through the pulmonary vasculature and driving a increased RV systolic pressures. And so HFpEF is going to be unlikely. However, if TRV max is above 2.8 meters per second, then HFpEF becomes likely. And if it's even higher, above 3.2 meters per second, HFpEF becomes highly likely. Unfortunately, the guideline does not really provide probabilities for these diagnoses. They just leave them in terms of words. And I think this is can be helpful in a clinical situation in discussion with patients, and can be a segue into going into the next step, which would be invasive hemodynamic testing. But really, this diagnosis has to be placed in that clinical context, depending on what the patient looks like and integrating all of the information. Some other potential indications. Some other more diagnostic value can actually be derived from a stress echo as well, and including a diastolic stress echo. So when running the stress test, we can also include much more information. We can look at left ventricular outflow tract gradients for obstruction. We can look at isolated changes to RVSP and pulmonary artery pressures as drivers of isolated pulmonary hypertension. We can also look at changes in severity of valve regurgitation, and we can also look at chronotropic competence as well. And so all of these can help us determine what might be going on with the patient. There are also some other potential indications for diastolic stress testing, which are not currently in the guidelines, but they have been proposed. And these are very kind of narrowly specific for certain conditions. For those, for example, with hypertrophic cardiomyopathy and dyspnea, diastolic stress test can help determine the relative contribution from LVOT obstruction and diastolic dysfunction. As you know, the thicker the myocardium in hypertrophs, the worse the diastolic function and the worse potential LVOT obstruction. And on the flip side, in those receiving myosin inhibitor therapy, such as mavacamten, a DST can assess improvement in diastolic function. And so that can be a data point that can be used to discuss with the patient. And also in athletes with dyspnea, a DST can differentiate between benign athletic remodeling and pathological hypertrophy as well. In this last part of the talk, I'd like to touch upon some considerations and challenges to be aware of when ordering and performing diastolic stress test. First and foremost, in the clinical situation, having a higher pretest probability will improve the usefulness of the diastolic stress test in ruling in and ruling out HFpEF. So running the test without a clinical indication or out of the blue is basically unacceptable, as it can lead to false positives. Technical image quality is always kind of the bane of echo, and we always try hard to get the best images possible, but at the end of the day, it may not always be possible to get them. So that's just something that's going to be a challenge. EA fusion is something that we have to be mindful of, and it will prevent early measurements of E and A velocities as well as E prime tissue velocities. So we have to wait until heart rate comes down. However, in patients with atrial fibrillation, where A wave is absent, we can actually measure the E wave right away. So in a little bit of irony, people with AFib might get a better value out of this test because we can measure the E velocities much sooner. TR velocity is also only acquirable, as stated in the guideline, in about 50% of patients. And so that actually becomes quite a challenge for the whole diagnostic algorithm, because if 50% of patients aren't able to have a quality test, then the value of test decreases. And also pathologies, a lot of different pathologies can provide inaccurate E prime velocities, such as insignificant mitral annular calcification, moderate to severe MR, significant AR that impedes mitral inflows, constrictive pericarditis, any kind of mitral valve repairs, as well as left bundle branch block. So all of those can affect E primes and will reduce the accuracy of the test. So we must consider just sending these kinds of patients direct to hemodynamic invasive testing. So in all, there are quite significant challenges and significant barriers to ordering a diastolic stress test, and some of these limitations can make the test not diagnostic. To finish up, I'd like to highlight the evidence base for diastolic stress testing using studies that tested the protocol for the diagnosis of HFpEF in the real-world population when compared to gold standard invasive testing. In general, we want to add the diastolic stress test when to a resting echo when we think the sensitivity for ruling out HFpEF is going to be a bit better. So DST, adding that DST essentially raises the sensitivity, and a high sensitivity of a test helps to rule out a condition or disease. One of the main studies supporting the use of diastolic stress testing come from Bokata in 2017, after the 2016 guideline was published, and that's in the left column here. They showed that a diastolic stress testing doubles the sensitivity of a resting echo compared to 2016 the resting algorithm. So sensitivity went from 47% to about 90%, which is a pretty good increase from the diastolic stress test. The evidence kind of becomes much more challenging to interpret after the 2025 guideline. There was a publication by Lababidi and team in 2025 that looked at using the 2025 resting algorithm, again, to compare it to hemodynamic gold standard testing and see how sensitivity and specificity compares. They actually found a huge improvement just in using that resting algorithm. They quoted and they found a sensitivity of 85% and a specificity of 87%. So it really almost captures both a 2016 resting algorithm and addition of the diastolic stress test. So these values end up being very good. But some concerns were raised about the study that they didn't specifically address how their population differed. All they said was that all the patients they included were referred for invasive testing. And so there was an assumption that perhaps a proportion of these patients had much more advanced heart failure symptoms. And that's why we had a pretty high pretest probability in these patients. And so are then adding a resting diastolic echo further increased the sensitivity and specificity of the results. Because the most recent study evaluating that same population using the 2025 algorithm by Harada, published in JACC in 2026, just earlier this year, showed actually quite starkly different test results. So they showed that the 2025 algorithm had a sensitivity of 29% and a fairly high specificity. So these results ended up being basically contradictory to what Lababidi found. And when they added a diastolic stress test on top of that, the sensitivity actually didn't even go up by much. So this kind of brought into question and made people wonder whether Harada's study was a bit of an outlier or whether a diastolic stress test has that much value to add to the 2025 resting diastolic dysfunction algorithm. What they did found to be very helpful is adding a higher pretest probability by using a clinical score such as the HFpEF score. And so their sensitivity was shown to actually jump by 2 times. So from about 32 to 64% when they use that score. So it highlights that we do want to have a pretty high pretest probability when we run a diastolic stress test. So overall, having a little bit of this contradictory evidence for the value of diastolic stress testing, I just wanted to highlight that this area is actively being investigated and the evidence base is evolving. And so that at the end of the day, we as cardiologists have to be mindful that this test can be helpful in patients with high pretest probability, but it also has pretty major imperfections and challenges as well. Lastly, I want to just touch upon that there are newer echo parameters in the pipeline for diastolic evaluation. The left atrium longitudinal strain software algorithm has been used fairly widely at this point by some bigger centers. And it actually ends up correlating with LV filling pressures quite well. And the benefit of this, as it's called, longitudinal strain reservoir, left atrium reservoir strain, is that it actually seems to correlate well independently of pathologies that might affect transmitral measurements, such as MAC or MR. The limitations to using this is that it's not widely available in most software packages on the echo machines. So it makes it difficult for smaller centers to adopt this. There are some other algorithms as well that are being developed, specifically with speckle tracking of the left ventricle and torsional forces and strain, as well as speckle tracking on MR. And there is also some artificial intelligence algorithms as well that have been published, and more are in development as well. So the field of diastolic functional and rest testing is evolving, and it'll be interesting to see what happens in the next few years. To conclude, there are some take-home points that I hope you guys can take from this talk. Diastolic diagnosis of early HFpEF requires a multimodal approach, including clinical score integration, resting and stress echoes, and consideration of going to invasive testing as the gold standard. Diastolic stress testing increases sensitivity for the diagnosis of HFpEF, which helps to rule out the diagnosis of HFpEF. And a moderate to high pretest probability, such as through the HFpEF score, further improves sensitivity of the diastolic stress test. And the most common challenges for diastolic stress testing include having trained echo lab personnel and equipment. There is also the technical difficulty of the study and being mindful of the order of parameters that must be taken. Also, TR jet prevalence is a big challenge, and additional structural pathology can make the diastolic stress test to be non-diagnostic. Thank you so much for listening, and I'm happy to answer any questions.